Colleagues, my name is Robin Room. I'm chairing this session, which is a very interesting session on working out costs of the health consequences for the society, for the government in particular, in terms of the health consequences of alcohol drinking and attributable medical care expenditure in Korea. This is a study obviously done in Korea, but opening up an avenue which I don't think has been so often studied in other countries specifically, although there certainly are a number of studies of looking more broadly at social costs of alcohol, including health consequences. And so I'd like to introduce Professor Sun-Ha Ji, who is chair and professor in the Department of Epidemiology and Health Promotion at the Graduate School of Public Health in the Yonghai University in Seoul. So who will make the first presentation of the study. Then we will have four commentators who will each give comments on it, and then we will have an open discussion, including the floor, of the issues in the paper and maybe the broader issues around it. Thank you very much. Please welcome Professor He.
Good morning, everybody. Thank you, Dr. Professor Robin Room, for a nice introduction for me. And I'm very honored to be here to present my work today, and I would like to talk about the title we talk about today is Health Consequences of Alcohol Drinking and Attributable Medical Care Cost in Korea using Korean Cancer Prevention Study. We have three main parts today. The first, I would like to talk about collaborative study with the National Health Insurance Service, and secondly, health effect of alcohol drinking, and lastly, we'll talk about attributable medical care cost of alcohol drinking. Before I start, I bring some slide about Korean most popular alcohol beverage about soju. Soju is one of the distilled alcoholic beverages native to Korea and is similar to liquor or Japanese sake. And in 1985, at that time, the Gangha cohort study began in 1985. The poor alcohol content was 25% for soju. Soju is a little bit hard drink in Korea at the time. At that time, soju drinkers account for 53.4% for male drinker, and another Korean most popular beverage is makgeolli. Makgeolli is an unfiltered alcohol beverage in Korea, and other one is beer and other alcohol drinker for 2.4%. So the reason why I present about soju, because our Korean cancer prevention study only use soju as an alcohol beverage because soju was most popular alcohol beverage at that time. And for here, I would like to introduce more details about Gangha cohort study. Gangha was located in west of Seoul, approximately 50 kilograms west from Seoul. The number of participants were about 6,000 people aged 55 and above. So in 1985 was a baseline, and then followed until now about 21 years follow-up study. But the participants are a little bit older, so now the more than 0.5%, now than 50% already died. And this publication is one of publication from Gangha cohort study. Although they have a very relatively small sample size for cohort study, they produced a very interesting study. This is one of alcohol consumption and digestive cancer mortality in Korean. This is the main finding. If we focus on this line, compared with the non-drinker and low, moderate, and high drinker means greater than 540 grams per week. These people increase the risk for esophageal cancer compared with the non-drinker. They have a 5.6 times higher risk than non-drinker. For colon cancer, they also increase the risk about 4.5 times higher risk. And bile duct cancer also increased about 3 times higher. As you see here, the number of cases is very small. Most cells have less than 10 cancer cases. Although they have very small cancer cases, the very nice good association between alcohol consumption and several cancer risk. And this is another publication from Gangha cohort study, binge drinking and mortality from all causes and cerebrovascular disease. In this study, binge drinking was defined as having 6 drinks of one occasion. And they focus on cerebrovascular disease. They focus on stroke risk. For total stroke, compared with the non-drinker, daily binge drinking, almost 2 times higher risk. It was statistically significant. And specifically, hemorrhage stroke. Hemorrhage stroke also increased the risk about 3.4 times higher risk compared with the non-drinker. So these 2 publications means this is a little bit older study, but there were nice association between alcohol consumption and cancer and cerebrovascular disease. And this is the more recent alcohol drinking survey. It was 2009. Still, Korean people like soju drinking. About 43% of Korean people drink soju, and 31% of Korean drink beer. And back to our presentation today, I would like to talk about collaborative study with NHIS. So the project title was Korean Cancer Prevention Study. It started since September 1st, 2001. Before 2000, in Korea, there were 4 different medical insurance systems. KMIC, Korean Medical Insurance Corporation, was one of 4 different Korean medical systems. KMIC provides insurance to the civil servant and private teacher and their dependent. And they also provide biannual medical examination every 2 years. And after 2000, Korean government make these insurance system into one national insurance system. Now we call it NHIC, National Health Insurance Corporation. So every Korean people belong to this one national insurance system. Then this year, they changed their name, the name NHIC into NHIS, National Health Insurance Service. And this is another timeline for collaborative study with the NHIS. In 2001, Graduate School of Public Health, Yonsei University proposed collaborative proposal to NHIS. Then we made a first contract 2000, September 1st, and we extended the contract in 2002, 2005, 2011, and until this year. And this is a Korean cancer prevention study. KCPS is an abbreviation of Korean Cancer Prevention Study. This is the overall study design of a KCPS. It is a 19-year prospective cohort study. All participants enrolled from National Health Insurance Service. As I mentioned before, everybody KMIC insured and their dependent. Then number of participants were about 1.3 million, aged 30 and above. And everybody asked to fill up the questionnaire to ask about the alcohol beverage. As I said before, at that time, soju is the most popular alcohol beverage in Korea. Although someone drink other types alcohol beverage, we asked how much soju you could drink instead of other types of alcohol beverage. As a baseline, in 1992 and 1995, we enrolled this 1.3 million population. At that time, medical examination participant rate so high, it was about 95% completed biannual medical examination. And then we follow until now. Over 19 years follow, we have already about 150,000 cancer instances and 180,000 cardiovascular disease events. In terms of mortality data, already 170 people were died. And this is for more details about alcohol consumption data. Total daily alcohol consumption was assessed by number of glass per week, and most popular alcohol beverage was soju. And 1 glass of soju contains about 12 grams of ethanol, 12 grams of alcohol. And we classified this alcohol consumption data into 5 categories. Non-drinking, which is 0 gram, and light, moderate, and heavy drinking. And very heavy drinking, people who drink 100 grams or more per day. And this is a general characteristic of a KCPS participant at baseline. It was 1992 and 1995. Average age is 45 years for men and 49 years for women. And for the smoking rate, most Korean people smoke a lot. 60% of Korean men were smokers. But for women, smoking were very uncommon. For drinking rate, about 77% of Korean men were drinkers. And for women, about 15% of Korean men were drinkers. And secondly, I'd like to talk about health effect of alcohol drinking. So to figure out how alcohol affects the incidence of cancer or other disease, we conducted this large-scale cohort study design. So for this, we used the KCPS study in this talk today. In 1992 and 1995, we assessed alcohol drinking status with the amount of alcohol drinking per day. And we followed between 1993 and 2011. And we figured out whether they developed any cancer, cardiovascular disease, and other alcohol-related disease. In this study, we ascertained 29 alcohol-related disease. And to figure out how alcohol related to risk of disease, we usually estimate relative risk. For relative risk, we calculated dividing instance among alcohol drinker and by instance in non-alcohol drinkers. And this is some data of drinking trend of Korean between 1989 and 2011. As you see here, in Korea, the prevalence of alcohol drinking is rapidly increasing since 1990. In 1985, about 78% or about 78% of men were drinkers, but about 24% of women were drinkers. But since 2000, the prevalence of alcohol drinking rapidly increased, particularly for women. Korean women drinking Korean women is rapidly increased. So, in 2010, Korean women drink a lot because I think that many Korean women participated social activity, get more job than before. Then this is one of our publication using KCPS. Cigarette smoking, alcohol drinking, and hepatitis B. These three variables were very well known risk factor for hepatocellular carcinoma in Korea. So in this paper, we wanted to see whether there are independent risks to the hepatocellular carcinoma or whether there are interaction between any two combination of risk factor. However, we didn't find any interaction between any two combination among these three risk factors. That means these three risk factors, smoking, alcohol, and hepatitis B, positivity independently associated to the liver cancer without any interaction. And then this is a relative risk of liver cancer by amount of alcohol for men and drinking status, yes and no for women, because at that time Korean women didn't drink a lot, so we only can classify the non-drinker and drinker for women. For men, compared with almost non-drinker, people who drink 100 grams per day increased about 1.5 times higher risk, about 50% higher risk for getting liver cancer for men. And this is all cancer. All cancer also the increased with as amount of alcohol increased for men. And this is esophageal cancer. Esophageal cancer, most strongest cancer in terms of risk of alcohol beverage in Korea. Compared with the non-drinker, people who drink, this is a very heavy drinker, who drink 100 grams per day, increased almost 6 times higher risk for men. And also women, almost 3 times higher risk, people who drink for women. And this is gastric cancer. Also, there were stabilized linear increase with the amount of alcohol beverage. And this is a CRC, colorectal cancer. So compared with the non-drinker, the relative risk for alcohol drinking on colorectal cancer was increased with the amount of alcohol drinking, whatever colon, rectal, and colorectal cancer. Very similar trend regardless of type of colorectal cancer. And this is interesting, little bit different style compared with previous result because relative risk of cardiovascular disease showed a little bit of J-shape. Someone say U-shape, means moderate alcohol were protective for cardiovascular disease. This is all cardiovascular disease, including ischemic heart disease and stroke. And if we selected ischemic heart disease, more protective. So in this figure, as increased of amount of alcohol drinking, the risk will be decreased. And this is about stroke risk by amount of alcohol in Korean men for total stroke and thrombotic stroke and hemorrhagic stroke. So regardless of different type of stroke, the risk of stroke will be increased as amount of alcohol beverage in Korea. About 30 and 40% higher risk compared with non-drinkers. And this is for women in terms of cardiovascular disease risk. Although there are a little bit difference, but if we select ischemic heart disease, Korean women drinkers had a higher risk than non-drinkers. This is a stroke risk, especially hemorrhagic stroke increased compared with the non-drinker. Korean women drinker increased the risk for hemorrhagic stroke. And then we talk about why the drinkers have a protective effect in terms of risk of cardiovascular disease. Because people who drink more, then the HDL cholesterol increased. HDL cholesterol, one of possible reasons why drinkers have a protective effect on cardiovascular disease. And then I look at the association with age and physical activity, but there is no significant association with amount of alcohol beverage. So HDL cholesterol is one of most possible reasons. And then we look at the combined effect, alcohol and smoking. Because in Korea, many people smoke, many Korean men still smoke a lot. So as you see here, this is all cancer risk. And we have a 4 group for the alcohol amount, 0, 1 to 24, and 25 and 49, and greater than 50. And increase the alcohol risk, the overall all cancers risk increased, both increase of alcohol and amount of smoking increase. This is esophageal cancer. As we expected, also there is very strong effect when we look at the combined effect, both amount of alcohol and amount of smoking. So people who drink 20 cigarettes, 1 pack per day, with almost 50 grams per day, compared with this group, non-drinking and non-smoker group, they have almost 16 times higher risk of getting esophageal cancer. And for stroke also, we found a very strong combined effect between smoking and alcohol amount, and all cancer. And we more breakdown for alcohol amount into 5 grams. So we have another group, the very heavy alcohol drinking here, greater than 100 grams per day. And still we have increased the risk in terms of a combined exposure. And esophageal cancer, similar finding as before, and stroke risk, similar. And now we summarize the relative risk of various disease by drinking status in Korean men and women. So for this presentation, we look at the 29 alcohol-related disease. So this is the top 10 most highest relative risk of various disease. For men, alcohol cardiomyopathy has most higher relative risk. It's about 3.5 for men. And secondly, alcohol polyneuropathy also higher risk, and as we expected, esophageal cancer also very higher level of relative risk. This is for women. And lastly, I will talk about attributable medical cost of alcohol drinking. To estimate alcohol attributable medical care cost, we need the data on population attributable risk. Generally, we use, to estimate PAR, we use Levin's equation. For this equation, the prevalence of alcohol beverage and relative risk of each disease will be have to be available. So already we look at the relative risk for each disease. And in terms of prevalence of alcohol beverage is very tricky because PAR is affected by prevalence of alcohol beverage. So this is overall trend, overall alcohol prevalence of alcohol beverage in Korea. So as you see before 1999, the prevalence of alcohol beverage among women were a little bit lower. It was about 24%, but nowadays the prevalence of alcohol among women increased up to almost 70%. So, but I think in this point we think about, do we need a latency period to look at between exposure, alcohol beverage as exposure to outcome variable. So in smoking study, we usually latency period for 25 years or even 30 years. In this alcohol epidemiology, I would suggest about 20 years prior to alcohol exposure when we look at the outcome data here. So if we use 20 years prior, then we have to use prevalence of here. And then this is the PAR. So in this study, we used to estimate population attributable risk. We used the prevalence at this point, about 77% among men and 24% among women. And then this is a list of population attributable risk of various diseases. This is top 10 population attributable risk by alcohol drinking, Korean men and women. So given same prevalence of alcohol drinking, disease with higher relative risk will be higher population attributable risk. That's why number one population attributable risk is alcoholic cardiomyopathy, and second was alcohol polyneuropathy, and thirdly esophageal cancer among men. And then how we calculated the attributable medical care cost of alcohol drinking. So we approached the disease specific. So we did disease specific approach. We selected 29 alcohol related diseases. So last year, National Health Insurance Service published one report. This is a very important report. They from this report, I selected 29 alcohol-related disease, and we already show relative risk for 29 alcohol-related diseases. Some of relative risk I just cited from Dr. Lee's report last year, 2012 NHIS report, and with relative risk. And then we can estimate population attributable risk using Levin's equation. And this is a list of 29 alcohol-related disease, from mouse and oropharyngeal cancer to alcohol poisoning. So with the ICD-10 code and with a reference. This is this is a relative risk for population attributable risk for each alcohol-related disease. I mean, this table includes RI and PAR for 29 alcohol-related disease for men and women. So most highest relative risk should be esophageal cancer. And this is a medical cost by alcohol drinking in Korea, 2001. So for each 29 alcohol-related disease have multiplied by PAR, and then we sum up to summarize total alcohol-attributed medical care cost in Korea. It was $1,361 in 2011. And this is the top 10 diseases attributed by alcohol drinking in Korea. Number 1 is hypertension, number 2 is ischemic stroke, and number 3 was diabetes. And now we revisit about latency period. In this slide, if I use a prevalence of at here, then this is a 661 million dollar. If we have a 20 years latency period, but if we use this prevalence here, 2010, that means no latency period, then about more than 2,000 million will be alcohol-related medical care cost in Korea. So there are big difference whether we use which point we use in terms of prevalence of alcohol beverage. So for the limitation, KCPS, we don't have data on types of alcohol beverage. We only use soju, the one soju, even although soju was one of the most popular Korean beverages, we don't have data wine and makgeolli and other types of alcohol beverage. And also, we only measure the single measurement for alcohol beverage at baseline 1992 and 1995. But people's amount of alcohol will be changed over time. So already we followed 19 years follow, so many people changed their alcohol habit. And lastly, alcohol consumption, this is the same limitation, is kind of we have to use kind of a time-varying exposure or time-dependent exposure, Cox proportional hazard model in near future. And to summarize, we showed relative risk and population attributable risk, 29 different alcohol-related disease in this talk. And in 2011, it was about 1,300, about $400 million. And this is a conclusion. In Korea, alcohol drinking is an independent, very strong risk factor for major cancer, particularly esophageal cancer, colon cancer, liver cancer, and stomach cancer, and also stroke, particularly hemorrhage stroke, and other diseases, other alcohol-related diseases. So the findings affirm the need for the aggressive alcohol drinking control in Korea in order to minimize the epidemic of a disease caused by alcohol. Thank you for your attention.
Thank you very much. I think the commentators and Dr. Jung should, Dr. G should come up, and we'll all sit around the table now, since we're not going to have any more slides. Is Professor Ronaldo Laranjeira in the house or not? Okay, so we have three commentators then. and each of them is going to give a comment, and then we'll open up for everyone for questions and for discussion, essentially. Okay, thank you. So Charles Perry has already been introduced to you this morning. So Charles, if you don't mind, I won't introduce you again, but welcome you to the podium.
Thank you. Thank you very much. Let's see which will be the best glasses to read from. Thank you. I'm very happy to be here again to speak on this important topic. We all know how important the link between alcohol and non-communicable diseases is. I must say that I had not seen the presentation before it was presented, but I had seen the abstract. So I'm working from that in my comments. But there was a lot of information in there, so I think I have a few things to say. I've got some general comments, then I'd like to talk about the methodology, and then end with the findings. In terms of general comments, globally, non-communicable diseases are estimated to account for 29% of all deaths, with cardiovascular diseases and diabetes, and then cancers accounting for the most deaths. Attention is often given to behavioral risk factors for NCDs, such as tobacco, smoking, and physical activity, and also to metabolic risk factors, such as obesity and raised blood pressure, but little attention is given to alcohol. Based on research undertaken by Jürgen Rehm, who was referenced, Kevin Shield and myself presented in Addiction in 2011, the percentage of non-communicable disease burden attributable to alcohol is highest in the former socialist countries with low mortality, in Eastern Europe and Central Asia, and also in low mortality, better off developing countries in America, Asia, and Pacific, where for men, 8% to 10% of the non-communicable disease burden is attributable to alcohol. However, in a follow-up paper which we have written coming out in the next issue of the NIAAA's journal Alcohol Research Current Reviews, we write the following: more detailed country-specific estimates are often limited by the validity of the available consumption and mortality data, and I should also say morbidity data. So that is why this Korean prospective cohort study is so important, not just to Korea, but to the world, because it provides information on an area where we don't have always good country information. So that's my general comment. In terms of methodology, the cohort studies are particularly powerful in demonstrating causal pathways. So I commend you for doing a cohort study. Other positives of the study include the range of levels of drinking among study participants, the length of the study period, the size of the cohort, although one needs to be careful with such a large size, as often small differences become statistically significant. The study is fairly novel in that it looked not only at the link between various risk factors and morbidity and mortality from selected cardiovascular diseases and cancers, but also at the costs attributable to drinking. In terms of risk factors, they looked at age, body mass index, which is linked to obesity, smoking, and drinking. Unfortunately, physical activity was not measured, nor were other risk factors that are believed to be important, such as fruit and vegetable intake, fat intake, high cholesterol, high blood pressure, and diabetes risk. I'm also, when I wrote this, wasn't sure that you looked at the joint effects of risk factors, but then during your presentation, I see that you looked at the joint effect of alcohol and smoking on stroke, esophageal cancer, and all cancers. But I think more work could be done to look at joint effects of risk factors. Finally, the findings. Other research has found a detrimental effect of alcohol on the following cancers: oral cavity cancer, nasopharynx, cancer of the pharynx, larynx, esophagus, liver, colon, rectum, female breast, and stomach, but beneficial effects of alcohol on cancer of the kidney and urinary organs and Hodgkin's and non-Hodgkin's lymphoma. What you found was a strong link between alcohol and esophageal cancer, your population attributable risk of 57%. This study also confirmed the global findings of the link between alcohol and cancers of the liver and colon. So in that respect, you really supported what we'd found in the global studies, but it's very, very positive to see the Korean data confirming the global information. However, when we look at strokes, slightly different findings. Global research has found a detrimental effect of alcohol on hypertensive disease, cardiovascular myopathy, conduction disorders, and other dysrhythmias, but a beneficial effect between drinking and ischemic heart disease, ischemic stroke, and other non-ischemic stroke. And I was interested to find that your study found that drinking increased the risks of morbidity and mortality from stroke, which is slightly different from what we have found globally. And I think I'm going to end there. Thank you very much.
Thank you, Charles. A very good start on the discussion. Now I'd like to introduce Professor Kwang Ki Kim, who is the director of the Indang Center for Alcohol and Gambling Policy, and also a professor at the INJE Institute for Advanced Studies in the INJE University School of Public Health.
Thank you very much, Chairperson. First of all, as a member of a local organization, a committee of this conference, I'd like to take advantage of this opportunity to express my thanks to National Health Insurance Service for having this session possible and for strong commitment to alcohol issues and leadership. Mr. Kim Jong-dae, chairperson of National Health Insurance Service, had made in process of this preparation. I'm going to talk about to make comments on policy implication of this presentation, and then some technical issues with respect to epidemiological methodology to measure alcohol consumption. Since Dr. Perry has already mentioned, I'm not going to make a comment on confounding issues in doing cohort studies. Last year, a group of international researchers on global burden of disease has published an article showing that use of alcohol became third leading risk factor globally. Alcohol use has been ranked sixth leading risk factor in 1990s global burden studies. However, in 20 years later, it became third risk factors of disease. It is followed by hypertension and tobacco smoking. Global burden disease studies plays a very important role in setting alcohol policy, priority advanced, and issue framing of alcohol policy by providing epidemiological evidence on how much harmful use of alcohol has negative impact on society as a whole. Dr. G's presentation has a special implication in terms of making estimation of epidemiological evidence on harms attributable to alcohol use in Korea, focusing on, in particular, medical care cost expenditure. We have very few epidemiological studies on harm caused by alcohol consumption in general, as well as direct medical cost attributable to alcohol consumption in particular. He concluded that we have spent more than $1,300 million to treat alcohol attributable disease, which is of equivalent of 3% of total health insurance benefit provided by NHIS. Here, I have some confusion of figures Dr. G have cited as a proportion of disease attributable to alcohol to total health insurance benefit based on study done Dr. Lee Sun-mi and her colleagues. I understand that Dr. Lee estimated it as a 5.3% rather than 3%. So I'd like to ask the Dr. G feedback on this figure difference. This substantial amount of medical cost we have spent underline the necessity to do an increased effort to reduce alcohol consumption in Korea. As a nation with social health insurance system, we have a big challenge how to make rapid increasing medical costs slow down in a rapidly aging society. Everyone in our society is concerned about the ever-increasing his or her health insurance premium. To implement cost-effective alcohol policies, three best by practice included in Seoul Declaration in particular is to secure way of preventing ever-increasing medical care costs attributed to alcohol consumption. I believe that NHIS should be active at front line in making cost-effective alcohol policy into reality, including efforts to increase alcohol prices. I think such efforts should be based on epidemiological evidence, just like what Dr. G is making presentation, in order to convince people who are not very reluctant to pay their money to buy alcohol beverage. For methodology of quantification alcohol consumption, Dr. G has mentioned. This study takes a most widely used method, which is quantity and frequency measurement to assess alcohol consumption with respect to resulting prevalence of estimation for healthless drinking and harms. QF method has some advantage as an assessment tool for those who have heavy drinking habit, just like a middle-aged man in Korea. But for those who are drinking moderate, just like most women in Korea, this method tends to underestimate amount of alcohol consumed compared to other methods, just like a graduated frequency and weekly drinking record measure. Further efforts to estimate harm attributable to alcohol must be taken into consideration different influence of assessment method into outcome. I found some confusion in quantification of alcohol consumption in several slides. We need to make sure how much of pure alcohol contain every glass of soju. Dr. G assumed 1 glass of soju contained 12 grams of pure alcohol. This assumption, I believe, do not reflect trend of lowering alcohol content in soju. 1 glass of soju contains only less than 8 grams of pure alcohol because we have soju of 16.9% of alcohol content per bottle, which is the most popular one now. Of course, some drinkers, old boys in particular, tend to drink soju with 21% or 23% of alcohol volume, rather than soju 16.9%. Even though we have converted glass of soju with 23% alcohol volume into pure alcohol, we only have 9.5 grams of pure alcohol in 1 glass of soju. So it seems to me Dr. G has assumed soju to contain 30% of alcohol volume of 1 bottle of 360 milliliters with providing 7 glasses of soju. I believe that this is not the case anymore for the most of drinkers in Korea. I want to know Dr. G's opinion on this matter too. To quantify relative risk and population attributable risk requires information on how amount of alcohol consumed for survey respondents by asking quantity and frequency of drinking behavior. As long as I understand, the questionnaire to measure drinking behavior used by NHIS tend to underestimate because of inappropriate wording of survey instruments. The survey instrument measuring drinking behavior says, "How often do you drink?" This wording do not make a specification of a period each respondent should refer to. Measurement tool of drinking behavior in Korea, Korean Health and Nutrition Survey asked respondents, "How often did you drink in last year?" So missing of the word of specifying period make a difference in estimating amount of alcohol consumed. So I believe that the figure Dr. G has cited from Dr. Lee's studies would be underestimated. Anyway, I believe that this kind of scientific evidence on harms associated with use of alcohol make great contribution to lowering tolerance of alcohol problem in our society, and also it make government in be strong position in implementation of cost-effective alcohol policy. I wish this conference make NHIS be an active agent in mobilizing efforts to reduction of alcohol-related harms in Korea. Thank you.
Thank you. And the third commentator is Young Ho Jung, who is a research fellow at the Health Policy Research Department of the Korean Institute of Health and Social Research. Please come. Yep.
방금 소개받은 한국보건사회연구원의 정용호입니다. I'm not a good English speaker, so I'm going to comment on Korean, but you're going to hear about interpreter with English. Sorry for inconvenience. 지선아 교수님 그 발표하신 내용 잘 들었고요. 아주 귀중한 연구 자료로서 향후에 활용이 될 것으로 이제 기대가 됩니다.
I think it will be very helpful in going further in this project.
아마 그 위험 요인에 따른 뭐 그 질병 부담이라든지 사회적 그 부담 같은 그 연구를 수행하는 특히 이제 한국의 연구자들께서는
The researchers in Korea who are concerned with the detrimental effects of alcohol are primarily concerned.
아마 그 한국인의 특성이라든지 그 한국인의 그 충분히 반영할 수 있는 역학 자료가 부족한 것을 충분히 아마 인지하고 계실 것입니다.
I think they have done a good job in recognizing the characteristics of the Korean people and implementing their project in line with it.
그래서 그 한국인들의 뭐 그 건강 위험 요인의 그 질병 부담을 추정하는 연구 결과들이 많이 그 발표가 되고 있긴 하지만
It is true that there are many research and projects that are going on estimating and doing research on the effects of alcohol, the detrimental effects of alcohol on the Korean people.
그 사용하는 역학 자료들이 주로 외국의 그 역학 자료를 이용하기 때문에
However, due to the research which is being primarily done from data and material of foreign researches,
그 연구 결과들의 어떤 그 크레더빌리티 아니 신뢰도 면에서 조금 그 한계를 가지고 있는 것이 사실이라 할 것입니다.
I believe it is so that there are some limitations and issues of credibility when it comes to the research that is done in Korea.
그런 의미에서 지선아 교수님의 이번 연구는 한국인의 특성, 내지는 한국인의 그 성향이라고 해야 될까? 조금 그런데 하여튼 한국인의 그 특성을 잘 반영할 수 있는 그런 역학 자료에 관련한 기초 자료를 생산하는 데 큰 의의가 있다고 할 수 있겠습니다.
And in this regard, I believe that Professor Ji's research was very efficiently done, and in taking into consideration the Korean people's characteristic, and will be a firm basic research for epidemiological progress.
그런 의미에서 그 한국인의 특성을 반영할 수 있는 잘 반영할 수 있는 그런 그 정보의 부족이 이 연구를 통해서 더욱더 개선될 수 있는 기회가 됐으면 하는 바람입니다.
And I also hope that through this research, that the formerly insufficient information concerning the Korean people will be fulfilled, will be complemented through this research.
그리고 그 알코올 그 관리를 위한 그 정보 정책의 어떤 근거에 기반한 그런 그 기초 자료로서 제공될 수 있다고 생각이 듭니다.
And I also believe that it is sufficient to be scientific based research that is sufficient for this undertaking.
그리고 제 개인적으로는 그 지선호 교수님의 연구 중에 그 알코올과 그 담배, 흡연의 그 결합한 그 효과를 그 연구한 그 결과가 상당히 저한테는 그 흥미로운데요.
Personally, I noted that the research that was done in combination of alcoholic effects and the effect of tobacco was very interesting to me.
현대인들이 가지고 있는 건강 위험 요인은 한 개 단수의 건강 위험 요인이 아니라 복수의 건강 위험 요인을 가진 분들이 다수를 차지하고 있다고 그 서베이 결과에서도 밝혀지고 있듯이
As the survey shows that it is not a single risk factor that the people of today have, it is a combination of risk factors.
이러한 그 결합하는 그 건강 위험 요인들을 결합한 그 연구는 향후에도 건강 수준이라든지 질병 부담을 연구하는데 커다란 그 활력소가 될 것으로 기대가 됩니다.
I believe this research will be a stepping stone in going forward in the epidemiological field.
근데 개인적으로 그 발표자분의 그 연구를 포함해서 조금 그 몇 가지 서제스천이 있는데요.
I have several suggestions, however, concerning the research.
우선 그 발표자께서도 말씀하셨듯이 몇몇 그 질병들은 그 알코올 소비가 증가함에 따라 relative risk, 즉 상대 위험비가 감소하는 그것들이 이제 나타났는데요.
As the presenter has suggested that through the research, it was shown that with the rise of consumption alcohol levels, there were some diseases which actually dropped.
그 저한테는 매우 그 흥미로운 결과라고 생각이 듭니다.
It was quite amusing to me to see this research.
저같이 조금 술을 좋아하는 사람은 굉장히 흥미롭고 아주 반가운 결과이긴 한데.
To me, as a drinker, it's quite welcoming research.
근데 조금 더 이 서포트를 받을 수 있는 보다 그 추가적인 연구가 필요하다고 생각이 듭니다.
But I believe complementary research is necessary in this area.
그리고 그 여성의 경우 발표자께서도 말씀하셨듯이 그냥 난 드링커 그다음에 드링커 두 가지 분류로 하셨는데 향후에는 좀 더 세분화된 그 분류로 질병 부담을 측정할 수 있는 기회가 있었으면 합니다.
The presenter also divided the drinkers in women as drinkers and non-drinkers. However, I believe the division should be more subdivided in further research.
그리고 이제 그 알코올이 가져다 주는 그 폐해가 질병뿐만이 아니라고 생각이 듭니다.
And I also want to note that the detrimental effects of alcohol are not limited to physical health.
뭐 조기 사망이라든지, 그다음에 생산성의 하락, 그다음에 음주운전에 따른 사고, 그리고 폭력, 그리고 알코올 중독이나 알코올 남용에 따른 빈곤으로의 추락 같은 것들이 포함될 수 있겠습니다.
Other side effects are traffic accidents, abuse of alcohol, and the social classes of lower incomes becoming, it has a detrimental effect on them as well.
그래서 그러한 것들을 포함할 수 있는 연구가 향후에 이루어졌으면 하는 바람이 있고요.
I hope that further research will include such areas as well.
그리고 그 영역에서도 관점에서도 개인 관점의 그 부담, 그다음에 가정에서의 관점에서의 부담, 그다음에 산업장 측면에서의 부담, 그리고 지역에서의 부담, 그리고 사회에서의 부담, 그리고 전 국가의 부담 같은 것들이 필드별로 좀 작성이 됐으면 하는 바람이 있습니다.
I also hope that more research will be done on individual burden as well as family and industrial, and going further to society and as a nation, there should be more research in this category as well.
그리고 이거는 그 발표자께 드리는 서제스천이 아니고 저의 국민건강보험공단에 드리는 서제스천인데요.
Now, the next one is not a suggestion to the presenter, but to the Korean government.
그 건강보험 그 자료의 접근성이 보다 조금 개선될 수 있는 기회를 가졌으면 하는 작은아마 그러나 커다란 소망을 가지고 있습니다.
I hope that the accessibility of personal information concerning insurances will be more accessible in the future.
개인정보 보호하고 그 다음에 공공의 이익의 관점에서 좀 조화로운 관점으로 시각으로 데이터를 연구자에게 제공할 수 있는 기회가 됐으면 하는 바람에 요청을 드립니다.
I request this in hopes that through the combination of protecting the private information as well as the public good, we'll be able to provide these information to the researchers for further study.
그리고 이건 추가적으로 저희가 작년에 수행한 연구 결과를 잠깐 설명을 드리고자 하는데요.
The next one is concerning last year's research that we have done.
알코올의 컨트롤을 위한 폴러시들의 OECD 국가들의 정책 관련한 비교를 조금 설명을 해드리고자 합니다.
I'd like to explain several factors concerning the OECD countries' research that was done last year.
OECD 국가들 대상으로 생산 측면에서의 규제, 그다음에 유통 측면에서의 규제, 그다음에 개인 차원에서의 규제, 그리고 시장 차원에서의 규제, 그리고 사회적 측면에서의 규제 같은 것들을 한번 지수화해 보았습니다.
We have looked into the regulations concerning production, society, and marketing, and we have put them into indexes.
그래서 그걸 가지고 통합 지표를 한번 산출을 해봤는데요.
And with this data, we have come to a conclusion.
우리나라가 차지하고 있는 알코올 컨트롤 폴러시의 위치는 그렇게 좋은 편이 아니라고 결과가 나왔습니다.
I believe that the results show that Korea is lacking in this regard.
한 30개 국가 중에 한 14위 정도를 차지하고 있는데요.
Korea is ranked 13th among 30 countries.
이런 지선아 교수님의 발표한 기초 자료와 함께 향후 알코올 컨트롤 폴러시에 보다 적극적인 관심이 정부를 비롯한 여러 그 전문가들을 포함한 그런 그 노력이 있어야 될 것 생각합니다.
I believe there must be more effort put into this policy with the cooperation of government as well as civil society.
제가 준비한 자료는 여기까지입니다. 감사합니다.
Thank you so much.
Professor G, you okay if we take questions and then you have a good comment at the end, or would you like to speak? Okay. Now? Okay. Very quickly.
I appreciate those three comment from three discussants. First of all, Dr. Charles Perry, he raised some different results in terms of risk of ischemic stroke. From the previous slide, ischemic stroke risk will be decreased as increase of amount of alcohol beverages. So I think at this point I needed to move further analyzing data. And thank you for the comment again. And from the second discussant, Professor Kim, Dr. Kim, he mentioned about why the alcohol attributable medical care cost is different between my data and from the last year report National Health Insurance Corporation, because we used different prevalence of alcohol beverage. I used 20 years before, the prevalence of alcohol beverage in 1990s. So that makes a big difference. So we need to think about more about this one. And also he mentioned about the absolute alcohol intake, one glass. So I think that his comment will be reasonable. So even I have a little bit of misclassification bias, the overall association will not be changed. So by the way, we need to think about more. And then lastly, Dr. Chung commented about he mentioned the harmful effect from alcohol will be not only a disease but also many side effects such as early death, accident, and poverty. So also I would like to do more further research. Thank you for comment again. Thank you.
Now we open it up to the floor. I hope I'm going to be able to see hands. Are there questions or comments from anyone on the floor? If you don't hurry up, I'll start talking. Is there someone? I can't even see behind the... No? No one? Let me start then while you're thinking about comments. This is really interesting to see this material. And the issue you raised, for instance, about the lag issue, it is interesting how differently the tobacco people who've mostly focused on cancer have behaved from the alcohol people who've mostly focused on cirrhosis when they were thinking about what was the outcome from the... and in the case of cirrhosis, then, there's a pretty stable finding that what happened last year matters for about half of the effect. Obviously, there's a 20-year effect in alcohol having a bad effect on your liver, but then the immediate policies in the year or two before, or the way the cost of living is going, can affect the people who already have a bad liver in terms of whether they die or not. And obviously, when you're dealing with the situation you are with women in Korea, where there has been this huge increase in consumption, then you have to begin to think of it more of the way that people usually think about it when they're talking about tobacco and cancer. It seems to me that, this is not to treat the history with any kind of cynicism, but in Korea, the two Koreas, we actually have an enormously interesting, very large-scale experiment. The alcohol consumption in North Korea, as I believe, is very, very low. It's at the sort of level that South Korea was, that the Republic of Korea was at the beginning of the data that you're talking about. And so there would be really, if any kind of cooperation on medical research could be arranged, it would really be interesting to do the comparison of what happens in a rather unified culture when you have two very different political systems and as a result, very different levels of drinking. One last little comment is that I'm a sociologist, not a biologist, but there's the Asian flushing reflex, the fact that a proportion of many Asian societies, people have an adverse reaction to alcohol, or at least flush if they drink alcohol from a genetic variant. And what we see in the Japanese data is that Japanese flushers used not to drink, but they do these days. And the result of that is that Jürgen Raymond and his associates have shown in a meta-analysis that the relationship between alcohol and cancer of the esophagus and so forth seems to be much stronger in Japan than it is in the rest of the world, probably because of this, or the hypothesis is it's because of the flushing effect, the people who are drinking despite the flushing, because that flushing effect represents acetaldehyde not being metabolized, and acetaldehyde is a carcinogen in its own right. So that your results for Korea may be, different from, with respect to those cancers, may be different from the results that you would find, say, if you were doing the study in Germany, for example. Now, there are more hands that that we can appeal to. Anyone else who would like to raise something on these issues? If you want to make any comment on that, then...
Also, the chairperson, one hand.
Okay, we got a comment? Sorry, excuse me.
No problem.
I would like to put you a question about cancer related with alcohol. Do you think that it's correct to start to speak about alcoholic terminal ill patients and the palliative care with cancer in alcoholics, as a specialist from Lisbon, the University School of Medicine, put it, because really in the last months they are terminal ill patients, and the treatments may delay for some weeks, 2-3 months, the death, but no more. And because I think this would be, it would be also impressive to educate people and to become aware of the dangers, because I would say that less is better, as in Paris was put it in 1995, but I think earlier is better. If you were to do intervention, earlier is better. And I think we are speaking about the situations when they are too late already. What do you think? I would like to have a comment from you. Thank you.
I think your talk is more like the comment rather than question. So I totally agree with your comment. So, and Rainer, I need to more think about the alcohol epidemiology. Thank you for your nice comment. And then I have a little response from the chairperson's comment. He also raised a couple of issues. Is some genetic difference between, some ethnic difference in terms of genetic. I think that if we have a good biospecimen, that we try to do to answer such a question, even we don't have such a biospecimen if we have a variable like flushing symptom after we drink alcohol. Also, we could use such a variable as a surrogate marker of genetic background. And also, he talked about we have two Korean, so we hope also good collaboration between South and North Korea for some comparison. And I think that's all. Thank you very much.
Okay, folks, your last chance for a comment or a question down here.
Thank you. I think the presentation allows us to see the importance of the health systems in the country that has provided the information that the doctor used for the research. I don't think this is the case for many of the developing countries. It's a total asset to have this kind of information, and I am sure the data in the national health insurance system will allow to have all these diabetes and other variables that we have talked. My question is, two comments. No? This conference, I think, is also giving us the sense of the importance to improve the national health systems in all of our countries, because all of us, we need to have this data and create the evidence as much as possible for local action in our countries. And the second is a question about how is the data available in the health system? Can you get this data in your system to make a further analysis on all the variables that you have been asked to further expand your research?
Would you say again the second question?
And the National Health Insurance System will have all the data that you need to
Yes.
make a further analysis that according
Okay.
with the comments you received.
Okay, so you talk about our special situation, unique situation in Korea. As I mentioned in my talk, we have a unique one national health insurance system. So I think we have a good chance to do this huge scale prospective study. But we have the same issue individual information protection. So all the data in the NHIC building, so every researcher have to visit to access the data. But there are a number of variables you concerned about, and also Dr. Chung mentioned about some access to these kinds of insurance data. I think that this year NHIC, National Health Insurance Corporation, has made a Korean representative database to provide data to Korean researchers. Its sample size is about 1 million data. So maybe I think the next year NHIC will provide these data to any Korean researcher if they want. Thank you.
Okay, one last comment, yeah.
In the prevalence data that you have given from 1989 up to 2012, soon after 1989 there's a sharp drop, and thereafter it's a steep climb, and then it stabilizes. So is there any explanation for that drop during that period? Is it anything significant, or is it statistical, just a matter of chance?
I think this is the relatively first time to see the prevalence of alcohol beverage in over 20 period, 1989 and 2010. There were big jump, big increase in terms of prevalence of alcohol beverage, but we need to look at in detail, because there should be changes the format, questionnaire format, or the questionnaire style. So we need to look at the more in details to compare the prevalence of alcohol beverage in between this period. Thank you very much.
Well, I think for all of us, it's been, who are not from Korea, it's been a welcome experience to have this trip into the Korean data and what it represents. This very large sample that you're dealing with. It must have been a little bit visionary for people to collect that larger sample and to ask questions about alcohol in a period when alcohol was not such a big problem in Korean life. And I think that we can learn that these large-scale enterprises of epidemiological studies can turn out to have very strong, really contributions not only to science but also to policy. And I look forward to seeing further analyses from you and your colleagues in this of this data. And I would like to thank the commentators as well as the presenter on behalf of all of us. And there is when we've finished thanking them, there's one more announcement. So thank you very much. Miriam, are you here somewhere? There's an announcement, I'm told.